Thanks for joining us again at the Canadian Breakpoint, a Canadian infectious diseases podcast by Canadian infectious diseases physicians. I'm Summer Stewart, here with Dr. Rupeena Purewal, Pediatric infectious diseases specialist from Saskatoon. For this episode, we welcome Dr. Rachel Dwilow, Pediatric infectious diseases specialist from Winnipeg, to discuss the current landscape of tuberculosis in Canada. Dr. Purewal.
All right. Welcome, everyone, to another episode of our podcast at the Canadian Breakpoint. So today we have a very special guest with us, Dr. Dwilow. So I would like to welcome Dr. Dwilow. Dr. Dwilow is a fellow of the Canadian Royal College of Physicians and Surgeons in General Pediatrics and Pediatric Infectious Diseases. Following her infectious disease fellowship training, she completed additional training in pediatric tuberculosis at the University of Stellenbosch in Cape Town, South Africa. She has worked extensively with TB-affected populations in remote, low-resource settings. Her current roles at the university include clinical lead for pediatric TB services, medical lead for the Winnipeg Regional Health Authority TB program, and the TB consultant for the Kivalliq region of Nunavut, Canada. She's the lead author of the pediatrics chapter in the most recent edition of the Canadian TB Standards. Welcome.
Thanks so much for having me. I usually go by Dr. Rachel or Rachel, so Dr. Dwilow seems too formal.
Totally fine. We'll go with Rachel or Dr. Rachel today.
Yeah.
Perfect. All right. Well, a little bit of a disclaimer. So obviously, Dr. Rachel was my attending physician in fellowship as well. So we've worked closely together. We've had some TB discussions, but I think things are a little bit different in Canada for sure and around the world. So why don't we start off by talking a little bit about the current situation of TB in Canada, just for our listeners to have an overview of what's changed, what are the outbreaks like, and what's going on in your world?
Yeah, so, I come from a Manitoba Nunavut perspective. So I don't know what's going on actively in other provinces over the last couple of years, but I can say certainly in the standards that the first chapter definitely does a nice job of describing the situation up until about 2000. And so Canada is really quite obviously the Canadian population on a general basis. It's considered a low incidence setting for TB. So we've been like fairly stagnant around 5 per 100,000 cases, the incidence rate. But again, that doesn't describe the entire picture, as I'm sure you know, having spent some time here in Manitoba. And, it's heterogeneous across Canada as to who's affected, but the general population groups at highest risk that we've seen in terms of what our epi data tells us is that this is a disease in Canada. Those who are foreign-born or have foreign-born relatives or live in the houses of foreign-born people. And specifically, as the data shows, higher risk from the South Asia region, which makes sense, high burden countries there, as well as the African region. Again, also not surprising, I think, for anyone that's done any work in the areas. Right. And then Indigenous. And so Indigenous includes both Inuit, First Nations, and Métis. And so depending where you are on the country, you actually get a really different patient population. So my population is very different in terms of who's affected than say in Ontario or say in BC versus Nunavut. So again, it depends where you are in the country. I know at least in Manitoba over the last couple of years, there was a decrease in case count, definitely, while COVID was happening. As to the reason why, I don't know. I don't know if we actually know or have data on that. But this year, it's come back with a vengeance. We're getting late cases, we're having more cases, and there are concerns with certain communities that, again, I won't name them, but they're definitely struggling right now. And I would say globally, that's been the case too. We saw cases go down, deaths go up from TB. So I think probably this is just a trend of what's happened with COVID and a lot of other diseases as well.
I agree. Yeah. So I guess for timing wise, I mean, the new edition for Canadian TB standards came out just in May here. So I think timing wise, I think it's very pertinent information, and actually reviewing the guidelines myself came across a lot of changes that I might not have been aware of previously. Mm-hmm. And so I think in general, just kind of discussion around like, was there a reasoning behind the new release, or was it just, time due for this to come out?
I don't entirely know. I was a later addition to the group. I know they had tried to do it right around the time COVID started. I think, it's Dick Menzies that leads the whole group. I think they had I think his goal was to update it every 5 years, but obviously I guess that didn't happen. It's a lot of work to do something like this. So definitely. I think it was on his plate, but on the back burner, and then he had some time and it was time to pull the trigger on it. So
that's fair. And
again, there's been a lot of changes as are reflected there in terms of treatment and diagnostics. So again, it was very timely and probably overdue as well.
Right. All right. So kind of, I guess, digging right into the guidelines, because most of our listeners, we've actually had a lot of requests for this episode.
Okay.
Yeah. And so I know, which is good.
I like it when people are interested in this. So that's great. Yeah.
Yeah. And I think it's because clinicians are seeing a lot of tuberculosis in their communities, and, our listeners they're international, but we do have a lot of listeners from North America, and especially in smaller communities, we're going to see outbreaks, things like presentation, right? So maybe we can talk a little bit about, because I know in the guideline, that was a recent addition as well, kind of comparing how like children may present very different from kind of our typical adult presentation that we see of tuberculosis. So why don't we touch on a little bit about that, and then you can give us an overall kind of overview as to an outsider from my standpoint, like what should I be looking in the guidelines and what are the newest things?
Yeah. So again, those of us who've studied pediatrics, children aren't little adults, as we all know, and again, manifest things very differently. I think the younger of the child, so an infant, is very different than, say, a teenager with TB. So I would say the more adult type symptoms, which are fever, weight loss, hemoptysis, prolonged cough, night sweats, you do see that in the more, I would say, teen to preteen. As to the age cutoff, like there's no hard minimum age for that. Yeah. So, but when you get into the infants, the big thing is, I would say to focus on is the epi-link or epi-contact. So when I see an infant and I'm thinking about TB, like who do they live with? Who are they exposed to? Do they fall into one of the risk groups that we know has a higher incidence in Canada? So again, recently immigrated to Canada from a high burden country, or one of our Indigenous populations. Again, not all are affected equally in Canada, and definitely it depends which region you're from. Yes. So when I think of the epi-link, then again, we also use the TST or the IGRA, depending on the age. Again, it's not to diagnose TB disease. So TB, when you're sick with TB, it's for TB infection. So when we're using that in terms of making a diagnosis of active TB in somebody, again, it doesn't tell me about TB disease. It tells me about immune response to tuberculosis antigens. And so then if my immune system or their immune system is responding, therefore that implies exposure, therefore that implies risk. And that's how I like to think about it. So once those two things are thought about, then you move on to like clinical signs and symptoms. And again, I see a lot of kids with just hilar disease or perihilar disease, mediastinal disease, I should say. So lymph nodes in the chest, which is very classic of pediatric TB. And actually, a lot of times they're minimally symptomatic. But again, you have to think about other things that cause that. And so, if you have that epi length, that to me is a diagnosis. I would say a child who's more sick. So you always ask about the TB symptoms, but you start getting into things like lethargy and irritability. And so weight loss or not interested in feeding, but not for short periods of time, for long periods of time, like weeks. And that's often what I hear when they're quite sick and you see the x-ray and you're like, whoa, okay. Yeah.
Okay. Yeah. So definitely a different presentation there. And then in terms of, so obviously that's a little bit of touching on the clinical presentation, now kind of walking through, so you have that clinical presentation, talked a little bit about the TST and IGRA. I know in the recent guideline, it was mentioned kind of the age group cutoffs, because I get this a lot in my practice, where everybody will ask, like, what should I send both? Should I be sending TST and IGRA both? Or what should we really be telling experts out there?
Yeah, so I would say amongst our group in our chapter, so the pediatric clinicians, lots and lots of discussion around the IGRA and the minimum age range.
Right.
And so previous to this, minimum age range, generally, amongst my colleagues was 5 years. So 5 years and up for the IGRA. And the reason for that is the immune system hasn't adequately developed. And as to when it's adequately developed within the first 5 years, that's hard to say, but a chance of a false negative. But there has been more evidence recently, and there's a really nice, I think it's a table in the chapter, talking about some of the studies where they use some large cohorts, and some like better evidence, I would say. I'm not sure if it's the best evidence, but that the IGRA can be used in lower age groups than 5. So pushing it down to around 2 is where we're at with that. So I would say, for sure down to age 5, for sure down to age 2, with some caveats. Again, if you're an abnormal immune system, maybe not.
Right.
I don't think you necessarily need to do both, but I would say I would use it as well. Consider more strongly using it in those who are BCG vaccinated. Again, the TST obviously reacts to that. So again, that's really also an emphasis. So BCG vaccinated should try and get an IGRA. Not the end of the world if you have a TST. Again, there's really good reasons to use a TST. Remote settings, because often the IGRA is not even available outside of bigger centers. So again, TST is just fine, and a good contact history and symptom history is also what you need.
Okay. And then just touching a little bit more on the workup, and then the real area I want to talk about is the management, because I think a lot of the updates are around there. So
sure.
In terms of, so do you want to just walk us through maybe, so we have a patient who we're suspecting TB, we would do the initial workup. So let's say it was somebody that you had high suspicion from clinical findings.
Yeah.
And so obviously as part of that, we talked about sending some of the diagnostic testing as well, like IGRA. And then what are some of the additional management criteria that we should be using?
So obviously initially it's a chest x-ray as well. And really, like, TB clinicians who spend all their time doing TB are so anal about this, and I am so anal about this, is it's a good quality chest x-ray. So you want to get that is one of your best tools. And so because you're looking at the mediastinum, you really need to have a great straight on view, good inspiration, good penetration. Any twisting or anything like that, again, really affects what you're seeing. And again, I've seen a kid who had a bad x-ray, bad quality, as we would label it, or how it's known. And then we brought him in, redid it, clearly TB disease. So again, really want to emphasize the importance of that and the importance of a good one. So there's that. And again, because usually it's going to be pulmonary is the most common thing. So that's where you start. but again, dictated on signs and symptoms. So certainly if there's signs and symptoms outside of the respiratory system, obviously imaging for that.
Right.
And then sputum. But most of the time our kids can't cough on command like an adult. So we use different ways to do it. So I would say gastrics are really popular around Manitoba, and because we also have blastomycosis here, so we use it for that. And so we send gastric aspirates after a period of being a fasting, I would say probably 4 hours or more. First thing in the morning is ideal, but I wouldn't necessarily admit someone to hospital just to do it, or a prolonged hospitalization just to do it. And so send those for AFB PCR if it's available at least once, which we also really want. We talk about that a little bit. And that's talked about as well in the adult chapters. And then obviously smears and cultures as well for AFB. And the gold standard again is usually an AFB culture or MTB complex on culture. Or, PCR as well. Positive PCR with compatible symptoms is also very appropriate. We also do touch upon a technique used in more lower resource settings of getting sputum induction even on young kids. And I think that probably relies on the experience of the nursing staff or the RT or whoever's going to do it. Because again, it has to be a good sample. So you can do it on babies. They do it in South Africa and India on babies. So again, it depends on what you have and what resources you have. But again, you can do it. So, if you have that and that's all you have, do it. Again, some sputum is better than none.
Right.
But, a lot of pediatric TB is, as a lot of you may know, is a clinical diagnosis. Again, we're really unlikely to have a positive smear or culture. So again, it's just a gestalt, an epihistory, and again, other surrogates like the TST or IGRA to make the diagnosis.
Yeah, and I'm actually glad that you brought that up, because there's a lot of times, obviously dealing with like being an infectious disease specialist myself, there's a lot of times when there's multiple things on your differential. And I think reminding kind of the listeners as well, but what I do in my clinical practice as well, is to remind them that like a negative culture or a negative smear doesn't rule
it out. Yes, definitely.
And that's a huge thing, because
and that's like, it's hard sometimes I think that's challenging for people to wrap their head around, even, here in our hospital. Serial follow-up is actually super useful too. So if again, you're not sure the kid's healthy, there's minimal disease or whatever is going on in the chest, a follow-up 4 weeks later, that's okay, as long as they have a reliable caregiver. Right. Sometimes when I'm really on the fence, because again, treating someone for TB and especially young children is a very big deal. It's a lot of investment in resources. And so really good short-term follow-up, again, can sometimes help clarify things with another x-ray. And again, if it's TB, it's going to be there. That's the approach I use when I'm on the fence.
That's good. Yeah. Serial follow-ups. I think that's really important to kind of reiterate too. So, okay. So I think in terms of our listeners should have like a bit of a grasp on, because there hasn't been too many changes around that. I know that there's in the guidelines more comment on age groups and cutoffs and volumes and that type of thing. So I think that's something that we can all refresh our knowledge about. But I think the area that was, I think, very, intriguing for me was where the guidelines kind of emphasized more talking about, first of all, just like drug susceptible TB. And so maybe we can talk a little bit about things that have changed in the pediatric world as well, but also in the adult world with LTBI, so TB infection management. So maybe what's the most common regimen? You can touch on that possibly.
Yeah. And so that's actually a really great point you brought up. I would say the most changes in terms of treatment in the standards is around TB infection, and even the name TB infection is different from latent TB infection, just because I think we, could talk about this longer, but again, TB infection is actually like a broad spectrum of things that we don't understand. So again, that concept itself is changing. And so really, I mean, globally, I think lots of low and middle income countries are actually farther ahead than we are because they have better drug access.
Okay.
That's just simply because, again, there's a bigger market. But really what we're, the focus in children and adults is the rifamycin-based regimens. So anything with a RIF in it is better than INH itself. And purely better, it's not that it's like there's an efficacy difference. It's that in the real world, people are more likely to finish a shorter regimen, and rifamycin-based regimens are definitely associated with less side effects than the traditional kind of longer INH regimens. So people like that. So that gets us into the two ones that are spoken about, which is the 3-HP regimen.
Mm-hmm.
So that's the 3 months of high-dose isoniazid and rifapentine, so once a week, 12 weeks.
Okay.
And then there's the 4R regimen, which is 4 months of daily rifampin, which again, because it's daily, it's considered reasonable to have that done self-administered. So again, in resource-limited settings, for whatever reason, there's no DOT worker to monitor intermittent therapy, so therapy that's not every day. Then 4R or daily rifampin is totally acceptable and has better completion rates than INH or 9-INH, 9 months of isoniazid. 3-HP is where it's at. So if you're over the age of 2, and obviously there's no drug interactions or anything like that, again, that's also a limitation of using rifamycin-based therapy, is lots of drug-drug interactions. So you have to be careful with that. But again, that's, 12 weeks of once a week is 12 doses total versus 4R is 120 doses. So completion is great.
Right.
But rifapentine is not available everywhere yet. It's considered special access by Health Canada, but we've been lucky here in Manitoba. And I know up in Nunavut have had access to it. So I use it whenever it's appropriate.
Yeah, that's good to hear. Perfect. It's great. And then going into more, I guess, management of TB disease.
Mm-hmm.
So are there any recent updates in terms of management change? I know that there's definition changes, or there's like addition of definitions for resistant TB.
Yeah. I would say the big thing to focus on, because DRTB or drug resistant TB is very small proportion. And I would say that encourage anyone, again, who's dealing with someone who has the possibility of having that or has that, to reach out to their tertiary care center, because it's very complex management, side effect wise, prolonged therapy. So again, I wouldn't do that on one's own.
Yeah.
So in terms of drug susceptible TB, obviously susceptible to all first line drugs, which is isoniazid, rifampin, pyrazinamide, ethambutol. So really what is being spoken about mostly is this standard 6-month regimen, which again hasn't really changed that much. So you have the 2 months of the 4 drugs, and then 4 months of 2 drugs. And then again, what's being brought up is to being a little bit more, I guess, less paternalistic about DOT, so directly observed therapy.
Mm-hmm.
It's felt, I think, in some jurisdictions to be really restrictive to people and maybe even bordering on infringement of their rights. And so, I think people are trying to back away from that and think about it more as treatment support, actually. So people that are gonna, like, I know some families that want help, and I know some families that are just fine. So it has to be obviously a discussion and
right.
Good follow-up to make sure that those who can, like, give them a bit more freedom. And they do mention that daily therapy is preferred over intermittent. There is some discussion about that, at least in the adult disease chapter.
Right.
But what's really exciting, and I forget if this was included or not, is there are studies out there, like clinical trials, looking at even shorter than 6 months now. So there's study 31, which is a rifapentine-based treatment that looked at 4 months of treatment. And then there's the SHINE trial in pediatrics that looked at 4 months as well for minimal disease.
Okay.
We're not there yet to prescribe it, broadly, but it's, people are working on this because, again, we recognize that some people don't need 6 months, but we have to figure out who those are and what the right drugs are.
Right. Yeah. No, that's fair. So I think, most of these kind of conventional treatments or standard treatments that we've used for a long, long time haven't changed much, but there definitely was mention about kind of our second line agents or agents when we are dealing with drug resistance. Now, obviously, in terms of everything we talk about today, even if we are clinicians, it's not medical advice, and it doesn't, it's really for discussion purposes and knowledge purposes.
Mm-hmm.
But touching on kind of what availability, so I mean, some of them are very available, like fluoroquinolones, for instance, we all have access to those. Are there certain drugs that are a little bit more difficult to access for second line that we should be aware of, that, we should be thinking about ordering sooner? If we're
so that gets really complicated. It's a complicated question here, and again, I don't have any. I've only had my monoresistance in my practice here, meaning isoniazid or rifampin or pyrazinamide. So we're not getting into the second line agents there really, but definitely at least here, things like dilamidid and bedaquiline are special access only, but they're great drugs. They're oral. It's unfortunate the availability is what it is. But I would say, in terms of choosing regimens, go to WHO's great publication and update on what is considered good regimens based on the group the medications fall in. So that's group A, group B, group C.
Right.
And they do touch on that in the standards. And I would also say, I don't know if we can readily accomplish this yet. It depends probably on jurisdiction and drug availability. We are trying to get away from aminoglycosides or injectable. Right. That's really being pushed globally, is all oral regimens for drug-resistant TB. Because again, aminoglycosides are super toxic, and people have hearing loss from them, and it's a really tragic thing. So again, that's really being discouraged globally. I think in some circumstances we do have to use them because they work, simply because we don't have access to all the other oral agents that other countries do. So
so talking about your practice then with like the monoresistant type, so if you have a patient who's like isoniazid resistant, like obviously we just talked about the regimen having those 4 drugs, and then the duration. So how does that change kind of what?
Yeah, so it changes agents, and it changes so you can't use isoniazid then, and it also changes duration, but again, it depends on which drug you drop. And again, they do talk about, I believe they talk about monoresistance and different treatment strategies, and that's definitely super widely available in the literature. Right. And often you have to go to 9 months, even if it's pulmonary. Again, and also depends on how extensive the disease is as well. Right. Which again, more extensive, more prolonged, but again, there's lots of great resources out there for monoresistant TB, like the Curry Center as well is a great resource from the US. They do really great education out of San Francisco, and lots of their stuff's available online.
Okay. That's really good. And then in terms of, since you see TB and you manage these patients, what intervals are we looking at, for instance, like side effect monitoring and that type of thing? Maybe we can touch a little bit about that.
Yeah. I'm not going to be prescriptive myself about that, but I would say follow the standards. And I would say, generally speaking, because I do a lot of remote medicine and things are simply just not available.
Yeah.
I can't do it. But I would say children, teenagers really don't need a lot of blood work, if any at all, after kind of the first bit, if they do not have side effects. It's a little bit different in adults with comorbidities on medications or hepatitis or whatever, where you're worried about liver toxicity, which is the big thing you worry about with 3 of the first line agents.
Right.
So again, we really don't do a lot of blood work regularly, but I would say really it's important in terms of monitoring is just talking to the patient about side effects and talking to them about things like signs of early hepatitis, which again is the thing that's going to kill someone. And again, knowing which agents to pull off and how to pull things off and how to reintroduce things is again, I touched on in lots of different resources. So I would say it's key to ask about side effects in early nausea, early vomiting that's persistent is hepatitis until proven otherwise. And jaundice, you've missed the boat. So I always get a little bit, at least that was what was always emphasized to me when I was in Cape Town, is any nausea and any vomiting that's, again, prolonged beyond 24 hours, you really need to think about hepatitis. So
yeah, that's good. Yeah, good point there for sure. All right. So yeah, I think we've touched on a lot of kind of the key points in the guideline. I did see that there was some mention of, I mean, you mentioned one of the trials, but future. So what is the future of TB prevention and treatment in Canada? Is there something that is coming soon or anything that you'd like for our audience to kind of be aware of?
Yeah, so I would say the couple of things we didn't touch on, which I kind of are really kind of quite big actually, which, maybe those outside of our TB world don't think they're that big, but they're things we've done for a long time that have changed. So not in the treatment for adult chapter, that there's no max to rifampin anymore.
Yeah.
Also, they make some BMI caveats in there, but again, we probably really underdose people on rifampin, and so 600 daily shouldn't be the cutoff. Okay. As to an absolute max, don't know, but they've been doing some really interesting things published that, with people with TB meningitis or extensive disease, like pushing it way beyond 10 milligrams per kilogram, and people really tolerating it fairly well. Based on, monitoring blood levels and things like that. So that's a really big change. It's such an important drug. Yeah. So again, I would say maybe that's actually more on the horizon. Maybe we'll see even greater dosing for that. Right. And I would say the other thing that's really, I think was really important in this that people talked a lot about was de-isolation. At least that's a hot topic, I know, in Alberta as well as in Manitoba. Right. And not being so restrictive about keeping people in for 2 or 3 weeks. Again, we know that's horrible for people to go through, especially if they're from a remote community and have to be brought somewhere else, right, away from family members, people who have jobs they need to go to. Yeah. Because again, there's lots of evidence out there that once you're on a regimen that works for your TB, you're responding to it, you become non-infectious actually quite quickly. Really quick. Okay. And so there's really nice review on that at the end of the standards. Okay. I'm not going to make any recommendations on de-isolation because that's definitely very controversial. Yes. But really controversial, but I would say give it some, amongst public health authorities out there, consider being less restrictive about it based on smear status, response, and responding and taking appropriate therapy. So again, if you have to be drug susceptible and on that therapy to respond, if you're someone with drug resistant TB, this conversation probably doesn't apply. Right. But again, for drug susceptible TB, certainly I think we can look at that and hopefully make more progress on that in the future.
That's great.
And I would say on the horizon, maybe not for like, I would say in terms of like, look out for shorter course regimens. Like, as I mentioned before, I think definitely there's lots of work being done on it globally. So maybe that's the future, but we'll have to see, certainly. And again, I think it's probably what's going to happen is you're going to probably stratify, if I had to predict, based on extent of disease will dictate length of treatment. How we do that, I don't know yet, but maybe a more stratified approach is what's coming. So.
Okay. And then currently, I guess one of the things I wanted to ask, just for my personal knowledge as well, is there a database that's like nationally that we're following? Are there Canadian trials in TB that are currently on the way?
Yeah, I'm not up on that. Well, I do know like Dick Menzies does a lot out of Montreal, does a lot. His main interest is TB infections. So I imagine there's stuff going on there. He does a lot of global work as well.
Okay.
I know there were some rifampin LTBI trials in the past. I don't know if there's anything ongoing now. Okay. But yeah, lots of stuff done. Again, we're a low burden setting. So it's our patient population is probably not a good bang for your buck. So, but I know lots of these people are in India and other places in the world doing work on these types of things.
Yeah, no, that's fair. All right, perfect. So before we kind of let the audience go here too, is there anything else key in the guidelines that we should be looking at as clinicians, or key take-home points, something that you're dying to tell us that we should know for sure about TB?
Yeah. What, if I had to say something, that's a good question. I actually hadn't like totally thought about it, that question specifically. Yeah, so I would say, well, pediatric TB always requires a high index of suspicion. And again, your history is crucial, and looking for signs outside of the classic adult signs are really what's key. And I would say for, what I think a lot of people felt very strongly about is that TB is more than just TB disease, and the families we see is more than just the medical treatment. There's a lot of other social issues that go along with it, housing and food insecurity and things that have to be addressed. And, all of us would love to have a social worker as well. All of us would love to have better access to all of these drugs being used in other places in the world. So just an appeal
Yes.
To anyone who's listening, more money, more availability. Yeah. And again, I think that's probably the state of TB in the world in general. Right. It's a huge problem, maybe not as much in Canada, but still it requires a lot of time and a lot of money if we want to eliminate it. So yeah, I think that's that's my message.
Awesome. No, that's really great. I mean, it's always nice to hear from somebody who's kind of managing TB daily, like even though a lot of us listeners are clinicians or pharmacists and nurses that are seeing TB, there's many angles to this. And
yeah, it's definitely just beyond the physician and the nurse. There's people giving people meds in the community that do such grueling work and find patients who are hard to find, and right. And public health is also a key ally. I speak to them all the time. Yeah. And again, implementing our programs and things like that. So it's a vast network of people just beyond me that deal with the patients that I see. So very thankful again as well, all the people who just really love to work in this area and do so much. So for so very little, actually. Yeah. So
I think it's also very helpful. I mean, we're really grateful for yourself as well, like authors like you that have been able to kind of change up guidelines, make current guidelines and updates for us, because obviously if we're not seeing TB cases as often, we're not really familiar with the current practice. And
exactly. It's all about volume. As I say, like like anything in infectious diseases. Once you see it 10 times, it lives like that.
Yeah.
But you know what, I also want to put a shout out there. That's very nice and generous of you for the thanks. But to Ian Katai and Dick Menzies as well. They're out there in the world. But I was very fortunate to be given this opportunity. And it was a collaborative effort. I learned so much, and these are experts and wonderful people. So again, always phone a friend if they know more than you. I do that for other things. So I'm always happy to provide advice as well.
Oh, that's great. Yeah. There's been multiple times when I've been in touch with you. So it's great. No,
Anytime. I love to talk about it and other things too, but yeah.
Yeah. So I think reiterating that the TB standards the reason I wanted to do this episode was just to remind everyone that there are updated guidelines and the standards are updated.
And again, it's meant to be an accessible document, right? It's not meant to be a super scientific thing. So again, that was as I think we spoke about before, that was the main goal. Yeah. It landed up being much larger because everything was so important to all of us. Right. So I hope it's useful to people. I really do. Yeah. And that people use it and give good care to these patients.
Awesome. Yeah. And there's actually a lot of information about kind of drug-resistant TB in there. I know some of our listeners had asked for, some elaboration in there, but I think the guidelines actually, after reviewing them, are fairly straightforward there. And then remembering that reach out to your experts.
I would say, even in places like South Africa, I'm on a group talking about some pregnancy and newborn stuff. If you're out in the community, you should not be managing that alone. It's complicated. Right. It depends what's available. And there's usually someone within your network that does this, and you should reach out to them and not be afraid to. I know certainly that's at least the philosophy with the people I learned from. So again, you're not alone out there. So again, and all of us, again, it's all TB is a team and a collaborative effort. So none of us minds, I think. So I would reach out.
Awesome. Perfect. Well, thank you so much, Dr. Rachel or Dr. Dwilow.
Just Rachel. Yeah. No problem. Thanks for having me and listening.
Yeah, it was awesome. All right. Thanks. Take care.
Thank you, Dr. Dwilow, for joining us. Have a topic suggestion? Email us at thecanadianbreakpoint@gmail.com and follow us on Twitter @CA Breakpoint. See you again soon at the Canadian Breakpoint.